Welcome to the Explainer. Grab your mental markers because today we're jumping straight into a super fast-paced whiteboard-style breakdown of one of the absolute most massive, high-yield topics in all of medicine. We're talking about heart failure. We're going to literally draw this out together, breaking down exactly how the body's most vital pump breaks and, well, more importantly, the pharmacological genius that we use to fix it. So let's get moving.
Okay, so let's dive right into this. At its absolute core, heart failure, or HF, is really just a mechanical failure. It's this complex, progressive disorder where the heart simply cannot pump enough blood to meet the body's metabolic demands. Just picture a pump that's totally lost its prime, right? The fluid backs up, the pressure drops, and the entire system just starts to suffer.
Now, to really understand this disease, you have to picture the daily journey of the patient. There are three massive red flags you're going to see. First up is dyspnea. Basically, they're constantly breathless, especially the second they try to exert themselves. Second is fatigue, which makes sense, right? Because their tissues are literally starved of oxygenated blood. And third, fluid retention, or peripheral edema. Gravity takes over, and suddenly their ankles are swelling up like water balloons. They're exhausted, they're breathless, and they're swollen.
So here's our game plan for today. We'll cover 1. How the heart fails. 2. Classifying the damage. 3. The treatment algorithm. 4. The pharmacological arsenal. And finally, 5. Side effects and warnings. Let's do it.
Starting off with Section 1, How the Heart Fails. Okay, so here's a question that honestly just blows my mind, like a totally confused neuron moment. Why on earth does the body accidentally make heart failure worse? Seriously, it's the ultimate biological irony. The body's ancient survival reflexes, the exact mechanisms meant to save you from a tiger attack or bleeding out, actually end up destroying an already failing heart. It's crazy.
And this perfectly illustrates what we call the vicious cycle. Think of the failing heart as this tired old horse pulling a really heavy carriage. Now, how does the body respond? First, sympathetic activation. It basically whips the horse, forcing it to run faster and pull harder. Second, it activates the RAS system, holding on to sodium and water. That's literally like tossing extra heavy sandbags into the carriage. More fluid, more resistance. The result? Step 3, myocardial dysfunction. The heart remodels, gets fibrotic, and our poor, tired old horse just drops dead even faster.
Moving right along to Section 2, Classifying the damage.
We generally divide this pathology into two main camps. On one side, we've got HFrEF, or systolic heart failure. Picture a weak, floppy, totally overstretched balloon that just can't squeeze the air out. The ventricle is unable to pump effectively, so we get a reduced ejection fraction. On the flip side, we have HFpEF, or diastolic heart failure. Now picture a stiff, thick leather pouch. It can squeeze just fine, but it literally can't relax and fill properly because of all this structural hypertrophy. So just remember, weak and floppy versus stiff and thick.
Now, how do we actually grade the patient's real-world suffering? We use the New York Heart Association, or NYHA, classification. Think of this kind of like grading a test, but here, a higher score is definitely worse. Class I? You're basically fine on normal exertion. Class 2, you're comfortable at rest, but, climbing a flight of stairs gets you. Class 3, marked limitation. Even super light exertion triggers symptoms. And Class 4, you are breathless sitting on the couch doing absolutely nothing. The physical effort needed to trigger those symptoms just shrinks and shrinks as the disease gets worse.
All right, Section 3, the treatment algorithm.
Treating heart failure is all about stacking polytherapy. It's a progression. In stage A, you're at high risk but have no symptoms. Here, we just focus on risk reduction. Stage B, you've got structural disease but still no symptoms, so we layer on ACE inhibitors or ARBs plus beta blockers. Stage C is when the symptoms actually hit. Now we're basically throwing the kitchen sink at it. Aldosterone antagonists, diuretics, air, and eyes. And finally, stage D is end stage, which requires highly specialized interventions. So we are quite literally layering on more and more drugs to block the body's vicious cycle as that heart progressively fails.
This brings us to Section 4, the pharmacological arsenal.
First up, we have the RAS inhibitors, or as I like to call them, the unloaders. This group includes your ACE inhibitors, those are the ones ending in pril, and your angiotensin receptor blockers, ending in sartan. Remember that heavy carriage we just talked about? Well, these drugs open up the blood vessels, decreasing vascular resistance, which is the afterload, and reducing venous tone, which is the preload. They take that massive workload off the tired heart so it can actually push blood forward. It's an absolute lifesaver.
Next up, we have the rate controllers and the volume dumpers. Diuretics, like furosemide, jump in to reduce plasma volume.
To put it super bluntly, they make the patient pee out all that massive volume overload, completely dropping the preload. Meanwhile, your beta blockers jump in to block that totally panicked sympathetic nervous system. They basically take the whip away from the driver, dropping the heart rate and chilling out the overdrive so the heart finally has a second to actually fill properly.
Now, what's really fascinating here is exactly how one of our oldest drugs, digoxin, works at a cellular level. It acts as a positive inotrope by directly binding to and inhibiting the sodium/potassium ATPase pump right there on the cardiac myocyte. Let's zoom in on that mechanism. We can break down this whole chain reaction with a super quick mnemonic. Just remember, block sodium, trap calcium, pump hard. Here's how it goes. Digoxin blocks sodium from leaving the cell. So, naturally, sodium piles up inside. Because that sodium gradient is totally ruined, the sodium-calcium exchanger just stops working, meaning calcium cannot leave. So now, calcium piles up inside the cell. And in cardiac muscle, calcium is the absolute hero of contraction. More intracellular calcium means the heart contracts significantly harder. Boom, positive inotrope.
Finally, Section 5. Side effects and warnings.
Okay, we really need to sound the alarm on digoxin for a second. It has a dangerously narrow therapeutic index. I mean, it is very easy to overdose. Toxicity starts with things like anorexia, nausea, and vomiting. Then it can trigger deadly arrhythmias. It even causes this completely bizarre side effect where patients literally see halos or have yellowish vision. And here is a massive, high-yield board exam warning. Hypokalemia, or low potassium, drastically increases toxicity risk. Why? Because digoxin normally competes with potassium for the exact same binding site on that pump.
Let's quickly fire through a few other classic, high-yield side effects straight from our pharmacology notes. ACE inhibitors are absolutely notorious for causing a dry, hacking cough and sometimes even life-threatening angioedema. If a patient gets that cough, we usually just switch them right over to an ARB. Then there's hydralazine, an arterial vasodilator. It carries this rare but super distinct risk of causing a drug-induced lupus-like syndrome. And neseritide, which is a recombinant BNP we use in acute settings, commonly causes hypotension and can actually worsen renal function.
So, obviously a crucial part of all this is knowing what not to do. Non-dihydropyridine calcium channel blockers, specifically verapamil and diltiazem, are absolutely contraindicated in patients with heart failure with reduced ejection fraction. Why? Because they have negative inotropic effects. They decrease contractility and can cause AV block. You never, ever, ever give a drug that weakens a pump that's already failing.
Wow, okay, we've covered the breaks, the fixes, the loops, and the side effects, but I want to leave you with this final, kind of provocative thought to chew on. If the body's natural compensatory mechanisms are what ultimately ruin the failing heart, and our absolute best pharmacological strategy is simply to block those exact mechanisms, are we actually curing the disease, or are we just cleverly buying time? Think about that for a second. Thanks so much for joining me on this explainer, and I will catch you on the next deep dive.